The most important factor that determines response to therapy beyond genotype is the presence or absence of cirrhosis. Patients with cirrhosis need treatment the most. Unfortunately, they are also the most difficult to treat. We see lower response rates or the need for additional therapy in many of our cirrhotic patients. Sometimes it's only based on whether they're 1A or 1B. Sometimes the differences are based on whether they have been previously treated or are treatment naive. But in all cases, with most regimens, either those that are approved or those that are in development, we have to tailor our treatment to the presence or absence of cirrhosis. Prior to considering therapy, you need to do a very comprehensive assessment of the patient. First, we talked about the need to assess whether they have cirrhosis or not. This has implications both for their treatment, choice, and duration, as well as for the need to do liver cancer screening and other cirrhotic healthcare maintenance. But other factors need to be considered. Certainly, we have to assess compliance. Though these regimens have far fewer side effects, taking any medication consistently for 12 to 24 weeks requires a compliant patient. We know we have less than optimal compliance when we use treatment for Helicobacter pylori for 2 weeks, or even a Z-Pak for 3 to 4 days. And so assessing the patient's ability to comply is of importance. And obviously psychiatric factors, comorbid conditions, the likelihood that they're going to be hospitalized or have other problems need to be assessed. Also social factors. Are they going to have a change in insurance? Are they going to take a vacation and have an interruption in their medications? All of those need to be assessed because patient compliance is critical to getting treatment success. And with very expensive medications, we want to ensure that this treatment course is hopefully 95+% likely their last treatment course. For patients who are still abusing IV drugs, it's a very difficult issue. On the one hand, we want to try to interrupt the transmission cycle. But we do have to recognize that the patient can get reinfected, that a cure is not preventative of reinfection. There is no protective immunity at current times, which means that we should also try our best to get patients into addiction management, because we don't want patients to be treated, cured, reinfected, and then require retreatment. We have to consider their comorbid conditions as it relates to concomitant medications. All Hep C drugs have drug-drug interactions that we need to pay attention to. Fortunately, there are a lot of online resources that allow you to assess those drug-drug interactions for both Hep C as well as HIV medications that are easily obtainable. I sit with that website open, look at the med list, and some of them are so simple. They have green lights, yellow lights, and red lights. You really can't go wrong. Traditionally, our mark for success for Hep C therapy has been called sustained virologic response, or SVR. SVR, which used to be defined as 6 months after therapy was stopped, is now 12 weeks after therapy has stopped. With the shorter course therapy, we don't see relapses after that first 12-week period. It has now been shown with the newer therapies up to 1 to 2 years, with the older interferon-based therapies now 5 and 10 years, that SVR, be it 12 or 24 weeks after therapy is stopped, is tantamount to virologic cure. So I tell my patients they are cured. because we know that over 99% of those patients will be undetectable for as long as you follow them. However, it is important to stress that virologic cure is not necessarily a cure of the underlying liver disease. For patients who have mild liver disease, they can consider themselves completely cured. For patients who have cirrhosis, they still carry a risk of liver cancer. The risk decreases over time, but at the current time, patients with cirrhosis are recommended for lifelong cancer screening, even if they are cured. And liver cancers have been reported 5 and 10 years out after a successful virologic cure with no detectable virus, just the presence of cirrhosis. And I guess that's expected since we see liver cancer in all forms of cirrhosis, even non-viral forms.